أهلا وسهلا بكم أعزائي الطلبة محاضرة Meningitis. Meningitis is inflammation of the meninges. The meninges, as you know, there are three layers. The perimeter, which is covering the brain tissue. The arachnoid, which is the layer in between. And the dura mater. بالعربية هذه يسموها الأم القاسية، هذه يسموها الأم الحنون. فinflammation of the meninges نسميه meningitis. Inflammation of the meninges may extend to the inflammation of the brain tissue, encephalitis, and the spinal cord. What are the causes of meningitis? Either bacterial infection, viral infection, fungal infection, inflammatory diseases of connective tissue such as SLE, cancer, and trauma. The most serious is bacterial meningitis. And from these causative organisms, meningococcal meningitis is the most serious type of bacterial meningitis. Pneumococci, streptococci cause around 38%, while Neisseria meningitidis cause 14%. Haemophilus influenzae was previously very common, but because of vaccination, it has been reduced to less than 4%. And rarely we may have staph or tuberculous meningitis. Acute bacterial meningitis is called purulent because we will see pus formation in the CNS. The mode of spread of the organism is to the meninges is through blood, hematogenous spread. And we see that in neonates, meningitis in neonate is very serious. It is caused by the causative organism is group B, or enterococci, listeria, and group D, pneumococci, and staph rarely. While in children, 1 month to 15 years, it was mostly caused by Haemophilus influenzae, or Neisseria meningitidis, or Streptococcus pneumoniae. In adults, the causative organism is mostly Streptococcus pneumoniae in around 50% of the cases, Neisseria meningitidis in 10 to 35%, and Staph aureus and gram-negative bacilli in rare cases. What are the predisposing factors for meningitis? Mechanical trauma may result in meningitis, as it will aid the entrance of the causative organism into the spinal cord or the meninges. Congenital defect, spina bifida and others, meningocele, immunological deficiency, such as cell-mediated immunity or humoral immunity defect. Splenectomy is a cause, especially in those with blood discresis patients, and neutropenia. What is meningitis? Invasive meningococcal meningitis most commonly present as meningococcemia or meningitis or both. We mean septicemia or with meningitis or without. The pathognomonic presentation of meningitis is the fever and signs of meningeal irritation, which include vomiting, severe headache, and high fever, more than 38.5, nausea, vomiting, photophobia, neck stiffness, altered mental state, and meningeal irritation signs. The pathognomonic feature is the acute onset, sudden onset of the disease, accompanied by hypotension, shock, and sometimes petechial purpuric rash or purpuric fulminans, and multi-organ failure. It is very serious in infants below 1 year because we may see that bulging fontanelle due to an increase in intracranial pressure. Meningeal irritation is diagnosed by knuckle rigidity, neck stiffness, Kernick signs, or Bodinski sign, and as we said, bulging fontanelle. These symptoms and signs are milder in viral meningitis and may be absent in the following group of patients: elderly or infants, debilitated or immune compromised, or those receiving anti-inflammatory or antibiotic treatment. These are the typical rash seen in meningococcal meningitis. So the presentation in infant is with or without fever, reluctant to feed, refusing to feed, high-pitched moaning cry, dislike being handed. The child is very anxious and with neck rigidity, blank staring expression, difficult to wake up, or pale, blotchy complexion. In older children or in adult, we find the stiff neck, headache, fever, vomiting, light sensitivity, photophobia, drowsiness and confusion, and joint pain may be seen in addition to fatigue. This is Kernick symptoms. When we extend the knee, severe stiffness of the hamstring causes an inability to straighten the leg when the hip is flexed 90%. When the hip is flexed 90%, it is difficult to extend. This is a positive Kernick signs. While Bodinski is demonstrated severe neck stiffness cause the patient hip and the knee to flex when the neck is flexed. Once we flex the neck, we see that the knees and the hip will be flexed by the patient. Classification. We have a probable case or suspected cases of defined turbid CSF with or without positive gram stain organism or ongoing epidemiological link to a confirmed case. This is a probable, while a confirmed case, suspected probable case with laboratory confirmation of positive CSF, either antigen or positive culture of the organism. We also classify meningitis into acute, subacute, or chronic according to the duration after the onset of the disease. We also have recurrent or bout of acute meningitis, recurrent. We must differentiate meningitis from meningism or pseudomeningitis when we have only irritation of the meninges and maybe misdiagnosed as meningitis. Meningococcal meningitis is caused by Neisseria meningitidis, is of particular concern because fatality may reach 50% or more, and also about 10 to 15% will get sequelae, the complications of meningitis. There is an area in Africa from Ethiopia to Senegal which is called the meningitis belt in sub-Saharan Africa, where 30,000 cases of meningitis occur each year. Infectious agent in bacterial meningitis is Neisseria meningitidis, a gram-negative cocci, serogroup A, B, C, Y, and W135. Reservoir is only human being. Mode of transmission is through respiratory droplet or direct contact with nasopharyngeal secretions. There is about 25% people carry the microorganism in their nose or in the pharynx with no symptoms, and they will transmit the disease, and only less than 1% will get meningitis. Incubation period 2 to 10 days, around, but usually 4 days. Period of communicability as long as the patient has symptoms or signs, but after treatment within 24 hours with antibiotic, the patient will be non-infectious. But special concern should be paid to the contact because of the risk of transmission. Close contact of case are at an increased risk of becoming colonized or infected. The attack rate of household contact is 500 to 800 times rate that of general population. So it is very high, 500 to 800 times. Risk of disease in close contact is highest during 10-day period following exposure. Method of control. Preventive measures. Health education, we have to educate the population about the avoidance of contact droplet method and reduce crowding. Vaccination. There are vaccines for A, C, and Y, and W135, and there is a polyvalent vaccine also. Patient on contact should be given chemoprophylaxis, and we have epidemic measures as we see. There is 3 types of vaccines in the United States. Control measures, we have the cases should be reported. Isolation is important. Concurrent disinfection of secretions and fomites. Quarantine is not applicable. Protection of contacts in outbreak, we cannot apply this because of large number. Investigation of contact, as we said, is important, and to give them chemoprophylaxis. Specific treatment, penicillin, ceftriaxone, or other drugs. chemoprophylaxis is given usually for 7 days for the household contacts, institutional contact also in the army or in the school or military group. In epidemic, pneumococcal meningitis can occur as part of cluster of pneumococcal disease. So we have to give vaccination for the area or the contact patients in addition to chemoprophylaxis. In nursery or also close contact patients. Control measures, meningococcal disease, either meningitis or septicemia, is potentially fatal, as we said, more than 50%. The Iraqi Ministry of Health recommends that any suspected case should be admitted to the hospital. And lumbar puncture is performed to exclude bacterial meningitis. The pathognomonic feature is the CSF. We see that the CSF is purulent, while in viral meningitis it is clear. So lumbar puncture is very important. Antimicrobial therapy should be instituted as soon as possible without waiting for laboratory results because of the serious fatal results if treatment is postponed. Once diagnosis of meningococcal meningitis has been established, many antimicrobial can be used. Penicillin, ampicillin are a drug of choice, or chloramphenicol. It could be used in spite of the possible side effects. Ceftriaxone, third generation cephalosporin are also used for 7-day course. Epidemic measures include vaccination. Mass vaccination campaign is carried out to stop the epidemic. Laboratory confirmation and epidemic subgroup will guide the type of the vaccine needed. But usually the type is known through the World Health Organization. For example, in Asia, it is mostly due to type C, while in Europe and in the United States it is type A. And recently, Group Y and W135, for example, it caused an epidemic in the year 2000 in Hajj or pilgrimage in Saudi Arabia. So, prevention through vaccination and give chemoprophylaxis to the close contact. Who need to be vaccinated? Individuals at high risk of the disease, especially aseptic, if the spleen is removed, or those with deficiency in terminal component or complement, immune deficiencies, traveler to endemic area, military recruits, and those exposed to certain type of outbreak, the school or nursery. Refugees camp are important, and even general population when an epidemic is suspected. Widespread chemoprophylaxis is not practical in epidemic cases. In epidemic cases, sometimes we cannot do lumbar puncture in large number of cases, and we depend on epidemiological and the clinical characteristic and start treatment. As I mentioned, chloramphenicol oily long-acting dose could be given in such cases. The less severe form with less complication is aseptic meningitis. Aseptic means that there is no bacteria, but it could be due to viral or due to malignant cells or chemical meningitis. Aseptic meningitis may be also due to bacterial, partially treated bacterial meningitis, or parameningeal infection, encephalitis or epidural abscess extending to the meninges, some other less virulent bacteria, Listeria, Mycoplasma, Mycobacterium, may cause aseptic meningitis, where the CSF is not purulent. But the most common cause of aseptic meningitis is viral meningitis. Rarely we see fungal or chemical or malignant meningitis or in SLE. So most common aseptic meningitis is viral meningitis, and there are many viral causative agents: adenoviruses, arboviruses, measles, herpes, and varicella. Reservoir is a human being. Mode of transmission, primarily through person to person. Vectors could be the cause. Incubation period, 3 to 6 days usually. Treatment, no specific treatment is available. Most patients will recover within a few days. Viral meningitis, 75% is caused by enteroviruses. So this is the most common cause of viral meningitis. Viral meningitis cannot be distinguished initially from bacterial meningitis, from signs and symptoms. So we need to do a lumbar puncture. Severe photophobia or knuckle rigidity or fever may be preceded for a few weeks by gastroenteritis or flu-like illness. Almost never involve the brain. Sometimes we see seizure fit in the patients. Self-limited disease resolved in 7 to 10 days, no serious sequelae. Viral meningitis disease is disease of the young, less than 40 years. The CSF, we see low number of white BC or polymorph. Glucose, serum glucose ratio is 50%. Protein may be high. Gram stain culture is negative. We can use PCR to diagnose the type of the virus. Approach to viral meningitis: treat like bacterial meningitis until 72 hours culture come back. Consider a cyclovar if the type of the virus is known. Chronic meningitis is a rare type caused by these types of microorganism, but it is a rare condition. The presentation here is insidious, slow progressing, low-grade fever, persistent worsening, photophobia. Diagnosis depends on history. The most common type of chronic is TB meningitis, and the diagnosis here is difficult. there are other types of chronic TB meningitis need treatment with multiple drugs as in TB, pulmonary TB. Other rare types are coccidiomycosis and the recurrent malarial meningitis caused by herpes, simplex virus type 2. So in conclusion, acute bacterial meningitis is most commonly caused by viruses than bacteria. Chronic meningitis mostly caused by TB, recurrent meningitis by herpes. And thank you.